welcome to Desert Wanderers, produced by Salt and Light Radio. If you're new here, we bridge the gap between you and the person in the pew next to you. I will be interviewing priests, religious, and laity in our local Boise diocese, asking questions that'll help you navigate your vocation and help build community wherever you are with whatever resources you may have. Let's build the city of God together. Well, welcome, Dr. Stroud. I'm so excited to have you on the podcast today. How are you?
I'm equally excited to be on your podcast. Thanks so much for having me on.
Well, for my viewers, what I would like to just kind of introduce you quickly, as I found you on Instagram and I was easily taken in and swept up in your content. And I just loved seeing someone that was so vocal about women's health and the things around women's health, but also in a way that is affirming life. And as you can see in the background, a lot of the times in your videos, there's always the Holy Family or a crucifix. And I just thought that was so inspiring. And so I'm really excited to have you on. But I think a great place to start, just to jump right into it, is if you could give us a little background about who you are, how you got into this work, and a little bit about your clinic.
Yeah, how I got into this work, I have no idea. It wasn't any grand plan of mine. That I can assure you. Maybe that'll come to light as we talk. But so I am in a practice called the Fertility and Midwifery Care Center. We usually just say FMCC because that's easier. And we're a group of physicians and nurse midwives and physician assistants and nurse practitioners and other types of providers that provide, full scope women's health care. But our real emphasis, or a big part of our emphasis, is on fertility, whether that means recurrent miscarriage or secondary or primary infertility. And then we're big advocates for what we would call physiologic birth. Some people would call that natural birth, to the point that we opened back in 2019 a separate facility called the Holy Family Birth Center, which is a freestanding birth center here in Fort Wayne. So we're a big, busy practice. We're pretty unique in the sense that we're completely independent. Now, nowadays, that's increasingly uncommon. We're not owned by a hospital. We don't have any financial interest or connections to any hospitals or hospital systems. And we practice in a way that is consistent with being authentically pro-life and life-affirming. More specifically, maybe for your listeners, we practice in a way that is consistent with and endorsing of the USCCB ethical guidelines. That's very unusual for an OBGYN practice. I wish it weren't unusual, but sadly it is pretty unusual. So we started this back in 2014, certain that we were going to fail, but it was just something we needed to prove that couldn't be done. And I guess God had a different plan in mind, because here we are 11 years later, and our biggest challenge is trying to see all of the people that want to see us. So we're very blessed and we're happy, and we have really an amazing work environment.
Speaking of work environment, you had a social media post a while back that I watched, and it was just all of your nurses and people that were working in the office, and they just had babies strapped to their backs. And I was like, this is amazing. One of the things that I'm really lucky about is working for a Catholic radio station. I've been really blessed to just tote my kids basically wherever I go, or have them when they're really little, I could have them in the office with me. And yeah, it's just a big blessing. So speaking of, again, about being pro-life, but also being pro-family, right? Mm-hmm. Not just that you have a right to live, but you have a right to be in society and be around with everyone.
Well, I tried to sort of, I guess, do maybe a shout out to employers, especially small business employers like me, to say, if you force women to choose between their job and their child, you will lose 100% of the time if it's the kind of talent that you want to hold on to in your company. So you either figure that out or rule out all of that talent. And so we've been really lucky. It's really sort of a community. At any given moment, there's a new baby in the practice. And so the nurses sort of just hand these babies around as needed. And it's really beautiful to see kind of the whole community coming together to help take care of little babies like that. It's really a lot of fun. And our patients love it as well.
I bet. I mean, I can only imagine, when you're waiting, anticipating you're pregnant, you're waiting and anticipating for your own child to just see a happy, giggly little baby around. I mean,
Right.
even if they're crying, it's still like, oh, they're just so small, they're so cute.
I think I
Um,
had a comment, it may have been on the LinkedIn platform where an employer type said, "Well, what if having babies in the office offended your customers?" And I said, candidly, then those aren't customers you want. I mean, if children offend you, then maybe we're not a right fit.
Right, right, absolutely. And you know what? I can even say for the radio station here when I'm doing some video for a pledge drive or something like that, and I had my daughter strapped to my back, people are like, "Oh, she's so cute," So that's always good news. But,
Wonderful.
oh, sorry, go ahead.
No, I was just going to say that's wonderful. I mean, that is, how can you affirm life more than that? And when you
No,
wear it
you can't.
around, it's pretty affirming.
Well, let's go ahead and get into some of the fertility awareness stuff. I
Okay.
think a big thing, in the Catholic circles, we have the Catholic teaching on contraception also surrounds this idea of fertility, and we're seeing it so much clash with maybe some things that are happening on the political level, where surrogacy and IVF are becoming more prevalent. But is that really? I guess in my mind, I'm thinking there has to be something better, right? When I learned about NFP, it was like, oh my goodness, finally something better than what we've been given. So I think what we should start with is what does normal fertility look like? And when do we see what is normal fertility and what are some signs that something may not be right and that we should kind of look into that?
Yeah, important points all. I mean, you remind me when you ask that question that it's important to remind ourselves that a state of being fertile is the ultimate vital sign for a woman, right? I mean, that is a state of health. In fact, to be infertile is evidence of unhealth or of disease. It's often the presence of fertility in the secular world is too often treated like a disease. We've got to protect you from it, right? Because it's a danger. But the reality is fertility is a state of health, the ultimate state of health. And so that's important to remember. You also remind me when you said that you referenced NFP and everyone hears natural family planning. They would say on a survey, virtually 100% of people would say, "Well, that's what people do to avoid pregnancy."
Hmm.
But family planning can just as easily mean to achieve pregnancy. It's data that you can use depending on your goals at the moment. So remember that fertility is a state of health. Now, how might someone know that something is up? You could come at that from a lot of different perspectives. One is just very practical. I'm not pregnant. Something must be wrong. Well, that's very correct logic. So you, not me, are designed to be pregnant. If you're not pregnant, that means by definition that something is amiss. And that's just not that complicated yet. Sometimes it sounds profound when I'll
Hmm.
say that to couples. But so if a husband and wife are engaging in the natural marital embrace, and it's been roughly 6 cycles of that, and they're not pregnant, something is wrong.
Yeah.
Waiting 6 more cycles is a waste of 6 more cycles.
Yeah.
So one way to know something might be wrong is I'm not pregnant and we're not avoiding pregnancy.
Yes.
It's almost a joke sometimes in our office. We'll say, "How long have you been trying?" And patients will say, "Well, I'm not trying, but I'm not trying." Well, there's no such thing, right? So if you're not actively avoiding pregnancy, even though it may not feel comfortable saying it, you're trying to achieve pregnancy. You just may
Right.
not realize it. So 6 good cycles of that, you should be pregnant. If you're not, there is by definition a problem. So that's a really easy definition. Other things would be some cycle irregularity. Now, I'm careful when I say that because irregular cycles don't prove that the woman is not ovulating. Regular cycles don't prove that she is. But some cycle irregularity, that could be a hint that there is something amiss. If you're using one of the better known NFP methods, maybe the Marquette method or the Creighton method or the Billings method, and you're struggling with the signs, the biomarkers, as we would call them, if they're not lining up, we kind of jokingly call that "I don't look like the book."
Mm.
There may be an issue. That's a good hint that something is going on. But I think those are some good kind of basic rules of thumb.
Could you talk to me for a little bit about women coming off of artificial birth control? And the only reason I ask is because I think that it's fairly common for women my age that are starting to have kids to realize, oh, I finally got married. We waited a while. Now we're ready to have kids. And guess what? I'm having a hard time achieving pregnancy, right? I'm having a hard time with my fertility, and then it might come out later. I've had a couple of friends that have actually gone through this, which is very sad. But they come off of it and then they realize I have a lot of work to do before I can even get pregnant because previously physicians, for better or worse, just put me on the pill at 15 because I had really painful periods or I
Sure.
had a lot of PMS or all these different kind of signs, right? That something may be wrong, maybe not, but
Yeah.
and then they have problems later. Could you kind of address that a little bit for me?
Yeah, I think there's two kind of basic answers in that one question. I mean, one is what we might call return to fertility after contraception. And
Mm.
so the manufacturers will, in their literature, will quote sort of normal return to fertility. You have to look at the small print carefully. Often that means within 1 year. If you're
Okay.
pregnant, they would call that a normal return to fertility. Most of us would think a year. Nobody mentioned that to me when I
Yeah.
started the pill at 15. But so that's an issue. Did the pill cause some challenges with cervical mucus or the lining of the uterus or of ovulation or of, what we call the hypothalamic pituitary ovarian axis, the communication between those three systems? Did it cause some issues that we need to figure out? So that's one body of kind of work. But the other one is, and I think this one is actually more common, was the pill covering up something that now that I've stopped it, it's uncovered? So the scenario that you use is something I see literally every day. The 12 or 13-year-old girl had horrible periods. She's missing soccer practice. She's in the school nurse, every month. She's going home from school early. Her mother's worried about her. She gets put on the pill for presumed endometriosis. And maybe a decade later, she's in that situation that you're describing. She stops the pill. She says, "Oh, geez, I feel like I'm 12 years old again. I'm dying over here. And by the way, I'm not pregnant." Well, that's because the pill was covering up a problem for that decade that she was on it. So both of those are real challenges, and we have to always try to figure out which of those two categories that we're in, or are you in both of those categories potentially?
Yeah. Could you just touch on endometriosis and PCOS, Polycystic Ovarian Syndrome, for me as a physician? Could you kind of just give us a brief overview of those are really common buzzwords, I think, in the fertility world.
They are. Yeah.
So if you could address that, that would be great.
Yeah, well, each of those could easily be a podcast in their own right, couldn't they?
Right.
Endometriosis is a bizarre condition. That's about the nicest thing I can say about it. Millions of women have endometriosis and don't realize it, or told they don't when in fact they do. It's an unusual condition where tissue that resembles the lining of the uterus, which is called the endometrium, tissue that very closely resembles that tissue is found outside of the uterus, typically invaded tissues in the pelvis. And it behaves as though it were endometrial lining inside the uterus. What I mean by that is during the first part of the cycle, when that lining of the uterus is getting thicker, it gets thicker and grows and
Mhm.
spreads. At the end of the cycle, when the lining of the uterus sheds, we'd call that a menstrual bleed. It sheds and bleeds inside the pelvis or wherever it is. Well, that sets off all of the inflammatory pathways. There's dead, necrotic, bloody tissue floating around the woman's pelvis. I mean, just saying it that way doesn't sound very pleasant, does it? And that can set off all of the inflammatory problems. And that can make things stick to things, that can cause pain. It can cause the tubes to be blocked or damaged. It can create this sort of toxic soup, you might say, that's toxic to sperm and egg. So it's a very bizarre condition. The most important thing that I like to convey to women about endometriosis is this: 50% of women with endometriosis have pain, painful periods, painful bowel movements around their periods, painful intimacy, mid-cycle pain, pain, and pain. 50% of them. The other 50% simply don't become pregnant when everything else is normal. So
Hmm.
almost every day I'll see a young woman, I'll say, "I think maybe you have endometriosis." And she says, "That's impossible. I don't have pain." Huh. I could flip a coin and I'll be right at least 50% of the time. So that's an important thing to remember. The absence of pain doesn't rule out endometriosis. So that's one big category condition. The other, as you mentioned, is PCOS, Polycystic Ovarian Syndrome. Sometimes you'll see it referred to as PCOD or Polycystic Ovarian Disease. They mean the same thing. And that is a very unusual hormonal syndrome that has to do with the hypothalamus, the pituitary gland, the thyroid gland, the ovaries, the adrenals. It's a very complicated endocrine syndrome that has several common characteristics. One of them, the woman tends not to ovulate or not ovulate regularly. She tends to have too much male hormone, specifically testosterone. She tends to develop insulin resistance, or her own insulin doesn't work as well as it should. So she has very irregular periods. Weight gain may be a challenge. Acne, unwanted hair growth is a challenge. And then on ultrasound, we see what's often called a string of pearls, where we see little bitty follicular cysts around the outside of the ovary that looks like a necklace. All of those things together make up the syndrome.
Mm. Interesting.
Now,
Okay.
I'm typically going to see a PCOS patient who wants to be pregnant. And what I mean by that is the ovulation piece is what's bothering her. But we treat in the moment what's bothering the patient with PCOS with an eye to the future. So it can be thought of as a pre-diabetic condition and heart disease and all of the things that go with that. So when I see the 14-year-old girl who's upset because she's never bleeding or bleeding all the time, she could care less about diabetes than ovulation. So I'll address her bleeding with an eye on the future, thinking about those things. But often by the time I see the woman, she's thinking ovulation, I want to be pregnant.
Right, right. That makes sense.
Yeah, I hope that
So,
helps. There's a lot we could talk about both of those, but I
oh
hope that
yeah,
kind of a global
absolutely.
sense.
Well, I just wanted to briefly touch on them because I think oftentimes when people are struggling to conceive, these are the two players. They come up the most frequently, I think.
Absolutely.
So I think to kind of go into our next question, right, would be what should someone do if they're having trouble conceiving? So they go through the 6 months and they're not pregnant and they haven't been avoiding. So what
Yeah,
should that person
what
do?
should or could they do? The first thing is recognize that's not normal. And so if you're talking to a provider that wants to write that off as normal, run, don't walk to the nearest exit, right? Because that's horrible advice that's just going to cost you time. So recognize that that's not normal. The second thing is find someone that is versed and competent and passionate about finding underlying causes of infertility. The causes are often causes, not cause. By that I mean it's often a multifactorial issue, not just one thing, but multifactorial. Those causes can almost always be known. And that's a critical thing to remember. Whenever someone says unexplained infertility, I can hear myself ranting on my own social media when I say that. More times than not, it means unevaluated or under-evaluated infertility. So I would argue there's essentially no such thing as unexplained infertility. So the causes can be known, and almost always those causes can be addressed. So to not be pregnant is a state of dis-ease or disease, and the causes of that can usually be known and usually be addressed. Those are the critical things. So you've got to find a provider that understands that. An easy way is a Creighton medical consultant that utilizes and is trained and certified in the Creighton method. There are certainly OBGYNs who will take a disease-based approach to infertility, but they're very hard to find. But they're out there. Make no mistake, they are out there. But if you can find a Creighton medical consultant or someone who is at least sensitive to the principles of the Creighton approach, you're in a good direction.
Are you specifically saying Creighton because of NAPRO technology or what that would be able to, those kind of providers that practice that?
Yes, I mean to be clear, yeah, and in medicine vocabulary can get so confusing, can it?
Yes.
When we say NAPRO technology, I think usually we mean the surgical philosophical approach to
Yeah.
causes of infertility, as opposed to when we say just the Creighton approach. The Creighton approach, really by definition, is a disease-based approach to pregnancy issues. Why are you not pregnant? We'll find a cause. Now, many times that cause will involve a surgical procedure, repairing damaged tubes, excising endometriosis, something like that. That's going to be someone like me that utilizes the NAPR technology approach and philosophy. I hope that makes sense, that distinction. It's really a non-distinction, but yet an important distinction.
No, I think it's really important. Thanks for continuing to give that definition and make that point. I think that's really important because we can kind of throw around, like I said, in the fertility world. Um, I think you do enough research on the internet, you feel like an expert, but you're really not. And I fall into that sometimes. So I'm really glad when you can kind of narrow in for me on what that means because again, it often is thrown around like, oh, you're struggling, then let's talk about NAPRO or, definitely talk about what your NFP, like whatever you're using for NFP, if that's Marquette or Creighton, what do your levels look like? But those are two different methods, and so
Yeah.
they're going to look slightly different on how you address those things. So I'm
Yeah.
glad when you can go in and pinpoint that for me.
But I think, again, hands down, the most important thing, recognize that's not normal because the secular world wants to tell you that's normal. And don't worry if there's a problem. One day you could have IVF, right? That's the
Yeah.
secular message that keeps coming up. But if you recognize that's not normal, and then I would say probably in the first 1 to 2 minutes of talking to a provider beyond nice to meet you, it's going to be very clear if they take a disease-based or a diagnosis-based approach to infertility because there is a reason you're not conceiving. But if you don't perceive that that's their approach, you're in the wrong place. That's okay. Just leave.
Yeah. What about I think we're seeing a trend in older moms, women trying to or have starting their families later. Does that have any effect on infertility or is that again, no, this is more of a sign that there is something wrong. It's not just that you're older. What does that look like?
I'd say yes to both of those questions. You know, I mean, there's some important realities about age that are objective truths. I like to say we're at our dumbest and our most fertile in adolescence, right?
Hmm.
So from adolescence, which is by definition the beginning of ovulation, until menopause, which is by definition the end of ovulation, there's a steady decline in a woman's fertility. That's just human biology. That's how we are made. So a 45-year-old is not, it's not going to be as easy for her to become pregnant as a 35-year-old, but a 35-year-old is not as easy as a 25-year-old. And so that's just human biology. There's nothing we can do about it, but it's important to know that. Where I think that comes into play is women find often too late that they've bought into the secular lie that you're in charge, you can postpone your fertility, go get your PhD, go be a CEO, you've got plenty of time. When that's a value-free statement to say, actually, you don't. None of us do. We're all living on a fixed number of days, and they all of us end in death. Sorry to be the bearer of that news if you haven't figured that out. And our fertility is just as objectively fixed. And so, yes, age matters. Now, the flip side of that statement is age isn't the only thing that matters. If you spent a day with me as a 45-year-old, you'd go home that day and think, wow, I'm actually pretty young. We have plenty of patients that are mid to late 40s who are pregnant and pursuing pregnancy. It can be more work, but it certainly is doable. There's the 35-year-old question that comes up all the time. I'll bet you've heard the expression geriatric pregnancy or advanced maternal age. I hate those terms. I'm pretty sure I have blue jeans in my closet that are older than 35, right? Um, but there is a biological reality, objective truth about age in that regard as well. What they're describing is the probability of a chromosomal abnormality in the child. So every time sperm and egg meet, there's a probability that the initial duplication of DNA goes catastrophically wrong and something happens. Um, that probability increases with maternal age. The miscarriage probability increases with maternal age because of that increase. And the thing that's always talked about is age 35, because at age 35, 36, 37, instead of being a straight line, it begins to increase exponentially. It begins to climb much faster than it did pre-35. So the probability of a woman having a chromosomal abnormality at 38 is significantly higher than it was at 30. And then what that translates into is the probability of having a child with trisomy 21 or Down syndrome is much greater beyond 35, 36, 37, because those children tend to survive to term. Whereas it wouldn't, if it's trisomy 18 or trisomy 11, they'll probably have an early miscarriage. We make a big deal about trisomy 21 and Down syndrome because those children tend to survive to term, praise God. So that's a reality. We can't change that. That's part of human biology. But every time husband and wife come together and pregnancy can happen, whether they realize it or not, they're accepting that biological risk. Whether you're 21 or 41, it's a different risk, but you're accepting that risk. Much like you got in your car and drove to your studio today, you accepted a risk of being killed in a car accident. You probably didn't process that in a way that you consciously considered, but yet you did at the subconscious level. The same is true about coming together to achieve pregnancy. So those are critical biological objective truths that I think are important to remember. Doesn't mean that you can't be pregnant at 45, but there are some realities you have to contend with.
I once listened to some, I guess it was a podcast on fertility, and they were talking about, so do women's eggs, we're born with the fixed number of eggs.
Correct.
So is it the reason that those towards the later years of right before menopause, is it because there's just fewer eggs released, or there's less eggs in the pot to pull from, I guess, or is that part of the
It's a
reason
great
why?
question. I mean, it really is the question and or one of the big questions in our world. And there's a lot of hypotheses, but not a lot of answers.
Gotcha.
Kind of the common hypothesis, you use your best eggs early. And so by the time you're 48, the only ones left over are not so good. That sort of has a logical appeal to it, but the truth is we don't know that to be true. But it is confusing. It isn't altogether clear. Where I thought you were going to go with that is this term that I absolutely deplore called egg quality. Have you heard that before?
Yeah, you hear that more when it comes to IVF, right? Your egg
Yes.
quality.
Well, and you answered the question for me because women will say to me, "Do you think I just have poor egg quality?" And then I often turn it back and say, "What do you mean when you say egg quality?" Because in reality, I have no idea what that means. In the IVF world, what they're saying is, what's the likelihood that I can take one of your eggs out of your body after I've artificially stimulated you to make 20 eggs instead of one? And I can fertilize that egg in a sperm in the lab with your husband's sperm that I've taken out of him and now artificially fertilize them. And then I take one of those embryos and I put them back in you. What's the probability that embryo will take, so to speak? And then they're going to use that to say you have good egg quality or not. But there's nothing natural about that whole thing I just described. So we can't speak to egg quality outside of an IVF lab. It's really an invented concept that we have to be careful. It has no meaning or utility, I would say, in the non-IVF world.
Yeah. That reminds me, I had a gal on and I think this actually happened off camera, but we were talking about fertility, and one of the things she said, she's like, I really, and not to say anything wrong with anyone that has chosen IVF because they have a lot of hard choices, right? And it's really painful to not be able to conceive. And
It
I think
is.
you know this more than anyone because you see it more often than I do. But so not to say anything wrong about the person and what they might be going through, but one of the things she said about IVF was it seems that children become a commodity because they're saying, I can pay all this money and then I can force it, not naturally, right? Like you were saying, we can take this not non-natural means of getting a child and then they can have that experience and I can force it. And it's now a commodity instead of a miracle, right? Where we have God
Yeah.
gives us miracles,
It's
right? So,
property that has to be inventoried and stored
yeah,
and taken care of. It is the ultimate of commodity and property.
yeah,
And many of your listeners probably know, but St. Pope Paul VI wrote about this brilliantly in Humana Vitae.
yeah,
And you can find that online. It's about a 30-minute read that will, in many cases, change your life. It changed mine. That's how I ended up sitting here in front of you. I read Humana Vitae with a friend once. But he described that exactly, that it's the most objectification of humans possible because you're quite literally creating humans in a lab and freezing them and storing them and inventorying them. So your friend's exactly right. She said it perfectly.
So let's talk about go into IVF a little bit. So
Okay.
is there something better than IVF? And I hope the answer is yes.
Well,
And
that's an
then when
overwhelming yes, not just yes, but an
and
overwhelming yes.
and from that, when we're faced with fertility troubles, what should someone kind of step into who might have been initially into the, well, maybe my only option is IVF?
Yes, I mean your only option is never IVF, and I like to say that a couple should never be forced to choose between their faith and what they know to be right and their fertility. There's always a better option than IVF. IVF does it never has to be the answer. And the Creighton model and NAPR technology in a disease-based approach to fertility, that is the better way. Why are you not pregnant? The IVF doctor will say, "You're not pregnant. It's okay. I can make you pregnant."
Hmm.
All of the patients that I see will say, I just struggled with them not caring why I wasn't pregnant. And it's not as though they're uncaring people. It doesn't matter to them why you're not pregnant because they're going to overcome that with the artificial laboratory-based conception. I say it has to matter why you're not pregnant because I'm not going to do that artificial lab-based method. So yes, there is a better way and you don't have to choose. But here's a little bit of tough love and philosophy that people don't like to hear that they have to hear. Children are not a right. They're a gift. And I feel morally obligated whenever somebody gives me the opportunity like this to say, not every husband and wife are called to biologic parenthood. It is just the truth. And you don't know if you're not becoming pregnant, if you're called to biologic parenthood or not, because you don't know if you're whole. Do you have a disease process or processes at play? My job is to answer that question, to fix everything that may need repairing. And then you and your husband find out if, in fact, you are called to biologic parenthood. But know this, the answer could be no. Sometimes that's the answer to our prayers.
Yeah. And again, I think that's a kind of important thing to state is that children aren't property, right? This isn't just a
Amen.
commodity that we can pick and choose when we want, especially the biological one, right? Because there is a call for adoption. You know, with the overturn of Roe v. Wade, there's going to be just inevitably there's going to be more options for adoption, and I
I
think that
mean,
we should
this is
call people
this
to
is
that.
good timing. I got a call from a private adoption agency just last week who said they cannot place most of their children that they're trying to place.
Mm.
So there's a secular message that nobody wants to adopt kids, and that's not true. But yet there's a problem linking those who want to adopt and those who need to adopt. And so adoption is always an option. I happen to have two adopted kids in
Oh,
addition to my three biological kids. But it is a phenomenal option that's always available to people. And that may be your calling. You've got to figure that out.
beautiful. Okay, so one before we kind of switch over into more of how you approach birth in your clinic, I wanted to ask one more question about finding an OBGYN. So if someone goes into an office, what are this like question? Give us like a few questions that they can ask that might be able to tell, oh, this person's going to be able to help me in a way that's going to be fruitful and maybe not.
Yes, so I would make an important distinction between you're looking for an OBGYN physician to help you with becoming pregnant and you think there's a challenge, and there's evidence maybe that there is a challenge. That distinction from I'm pregnant and I'm looking for someone that I want to care for me during pregnancy.
Yeah.
The second one is a lot easier than the first. So the second one often has a lot to do with are you nice? Are you competent? Do you generally support my wishes and my views? And will you support them if they don't necessarily agree with yours? That's not terribly difficult. It can be depending on where you live and what your wishes and views are. But don't confuse those two because on the fertility side, it's a hard stop. If you don't agree with what I'm trying to do, we cannot work together.
Right.
If I say I'm not interested in IVF, and every time you and I meet, you bring up IVF, this relationship is going nowhere. So that one is more difficult. But just in general, if you're pregnant and you're in that second group, ask people about questions that are important to you. Do you support physiologic birth? If I do, what if my views of what is best differ from your views of what is best? How do we get along through that? And then my favorite question to ask when you're interviewing someone and you're already pregnant, tell me about your model of care. Now, what I
Mm,
mean by that is maybe you and I meet and you like me and you're pregnant. You think, oh, I'm going to come to this person. I like them. What happens if I'm sick? What happens if I'm on vacation? What happens if I have a sick child or a sick spouse and I'm not there when you go into labor? Oh, that's okay. One of my 20 partners will take care of you. Well, what if I don't like them because I've never met them? That's the model of care. How do you get care done? Do you utilize nurse midwives? I highly suggest finding practices that utilize nurse midwives. In transparency, I'm married to one and we have six in our practice. So, yes, I have a huge bias. But physician midwife practices, I would argue, are the best. But find out what the model of care is. On the fertility side, you've got to find somebody that supports a disease-based or a diagnosis-based approach to fertility. And that's a hard stop, as I said.
okay. So then let's go into your practice a little bit and
Oh,
talk about, I guess, what typical birth at like a hospital might be versus what your clinic does. So how are you different than a hospital-based birth?
yeah, it's a great question. Let's say hospital first. Um, Hospital, our agenda, I would say, when it comes to birth and birth experience, is to get you your agenda, whatever that is. Now, because we feel that way, we end up with a disproportionate number of patients who are interested in a physiologic approach to birth. That is to say, they want minimal intervention. I don't like to hold myself and my group out as minimally interventional. I like to say we're appropriately interventional. Sometimes I cut somebody open and take the baby out. Well, that's called a C-section. And I don't think you could be more interventional than that. But it's the appropriate use of that intervention that matters. But because we feel that you should get what you want, we end up seeing people that tend to want something they can't get other places, or at least they struggle to get other places, which is a physiologic approach to birth. I don't want to be induced unless I need to be. I don't want an epidural. I don't want a bunch of pain medications. I want labor to begin spontaneously, progress spontaneously, and I want the birth experience that I want. Now, that birth experience could be I want to make sure my hair and makeup are perfect. I want to be induced at 39 weeks, and I want an epidural. Well, if that's the experience you want, that's what we want to get for you. Most of our patients don't look for that experience because you can get that experience almost anywhere.
Right, right.
So we try to get families the experience that they want in the hospital even if there's a pregnancy issue. Just because you have preeclampsia and maybe you need to be induced doesn't mean you have to have a horrible birth experience. And too often that happens. It's a slippery slope to, gosh, I wanted to do this and this and this in labor, but I had preeclampsia, so who cares? It's like I ate one potato chip on my diet, so I'll just eat the whole bag. No, it doesn't have to be that way. Um, but so in the hospital setting, we try to get patients the experience they want. Now, as I mentioned, we operate a freestanding birth center that has nothing to do with a hospital. It's called the Holy Family Birth Center. Go to fortwaynebirthcenter.com. There's a plug for our birth center. It's got videos and pictures, but an out-of-hospital birth for properly selected patients who qualify for that is truly birth as it was intended. That's our tagline, but it's more than a tagline. It is. It's just the truth. But an out of hospital birth can be the most beautiful thing that anyone could ever experience. So, if nothing else, watch the videos on the website to get a sense of what I'm trying to describe.
And I'll make sure to link it down in the description so that people can check that out.
Well, thank you.
Um,
If you're looking for a birth center, it depends on where you live in the country. Every state
mhm.
manages that differently. Their state health departments manage that differently. But you're interested in an accredited birth center by the Organization for the Accreditation of Birth Centers, the AABC. And any birth center that's accredited is going to put that front and center on their website. But that's critical from a quality and a safety standpoint. You want an accredited birth center.
Another thing I was gonna that you made me think of actually talking about natural birth is um, is my doula. I had a doula and she was talking about she did this really awesome program. So right before you um probably like around 30, I think it was like 32, 35, right around there. She sets up this activity where you go, okay, what do you want your perfect birth scenario to look like? Dream it up. And then she says, pick five non-negotiables. And she's like,
I
we'll
like that.
always give you a positive birth scenario, but we want to make sure that we want to know because labor is so intense, we want to know which things are gonna if we're starting to get to the point where you're getting really uncomfortable, you're kind of starting to get into the suffering kind of thing, like what things can we try that you'll be okay with. And I think that's really helpful. I remember my first child, I had this idea of what birth was going to be like, and I had this all lined up, and we even did the exercise and everything, and nothing happened, but it was still beautiful, it was still fine. But nothing went like it was supposed to. And I think that's all too common for people.
Right.
I think it's just like, well, it is a birth is just what it is. So
I like to use the wedding planning analogy. And what I mean by that is if you plan the most spectacular June wedding there is and it rains, you don't cancel and go home, right? You
yeah,
had a fallback plan. You still get married. It's still great. It's still a lot of fun, but it's different than you planned.
yeah,
I think the probability of happiness goes up if you can approach your birth. Plan the perfect birth because that's how you figure out what's important to you. At the same time, you have to recognize this is biology. This is human biology and it's most complex. Plans sometimes change, and that's okay.
yeah.
Lean into that. It's all right.
Absolutely. So this is another great, I think we'll kind of taper off on this and then we'll hit your social media platform so that we can get
Uh-oh.
some more some people to see your stuff because I'm telling you, he is so entertaining. I love his Instagram. It's great. But what I was gonna ask next had to do with postpartum. So after you have a baby, you are in postpartum for it could be anywhere from some women get pregnant at 6 weeks, which I goodness gracious. And some people have like 2 years before their fertility returns. So medical professionals say you should wait 18 months before trying to conceive again. Is there any medical basis behind that question?
Absolutely not. That's the easiest question I can answer. No medical basis behind that at all. Remember, this is a naturally designed and ordained process. It doesn't need managing. Now, hear me out. There are complications of pregnancy where we might recommend a certain degree of spacing for safety for the next pregnancy, but that's unique. But in general, the scenario that you kind of lay out, we had our child, it was uneventful. What could we or should we do next? It should be based solely on your desires for your next pregnancy. No medical reason at all to delay another pregnancy. Not at all.
And then I kind of tying it back into where we started and talking about if you're not pregnant, there's something wrong. If you're having very long postpartum periods, is there something necessarily wrong, or is this kind of get into some gray area when it comes into breastfeeding, if you're breastfeeding, or all those kinds of things? So, what does that look like as
It
well?
most definitely depends. I sound like a politician, right? It depends in large part on breastfeeding. Some women that are breastfeeding will not have a period as long as they're breastfeeding. Even if they're breastfeeding twice a day for comfort, they'll not menstruate or ovulate. Other women will ovulate 56 days after they give birth, breastfeeding or not. So, of course, if you want to not be pregnant, if you want to avoid pregnancy, you have to assume on the 57th day after birth that you are fertile, even though you may not be menstruating,
Mm.
because about 40% of women will ovulate before they menstruate the first time after a birth. So, if you don't want to be pregnant, you have to follow that rule 56 days and you're fertile. So, it can be challenging. I would say postpartum breastfeeding, that season, is the most complicated for couples using NFP to avoid. Now, if you don't care if you become pregnant again, it's fine and fun and doesn't matter. But if you need or want to avoid pregnancy, that can be a challenging time. And you need to work with an NFP professional to really help you work through that so you can achieve what you're trying to achieve.
Is there any medical reason? So is there any so after, pregnancy can drain from what I understand, pregnancy can drain us of a lot of nutrients from our body. And so is there any reason that postpartum would last longer because your body's trying to build those back up and is not restarting fertility? Or is it more so that it just depends?
I think it just depends. This again is fascinatingly complex human biology. But there's nothing wrong with not menstruating when you're breastfeeding and not being pregnant for, a year or 2 years if it's explainable. We can figure out in the breastfeeding mom if she's ovulating. If she's not, we know why she's not pregnant. And unfortunately, some women have to choose between breastfeeding, continuing breastfeeding, and
Yeah.
becoming pregnant again. That's not always the truth. I certainly have plenty of moms that conceive while breastfeeding, and that's okay. But it really depends on her goals and what she's trying to achieve.
Yeah,
But there's
absolutely.
nothing that you have to do to become fertile again. Again, you're wonderfully designed to do this. So there's nothing that you have to know and you have to do.
Yeah, with my first, we actually conceived 5 months postpartum, and it was hard. It was hard to realize like my milk supply was dipping to a point where I ended up having to not breastfeed anymore.
Yeah.
But it was funny because I was like, I thought I was supposed to be safe. 'Cause I learned a lot in that first one, the first go around,
Yeah,
and the
remember that
whole
56-day rule. Yeah, if you're exclusively breastfeeding for 56 days, you're not going to ovulate. Day 57, you have to assume you could. Now, you may not, but you have to assume that you could.
awesome. Okay, so where can people find you? Where can they learn more about your clinic, or learn more
Oh,
about your
gosh.
practice?
I can't imagine why anybody would want to. But if you're so inclined, myfmcc.com is our practice website, myfmcc.com. You can learn a lot about us. And even if you're listening in California, I think if you look at our website, it might help you learn what you might be looking for
Yeah.
wherever you happen to live. Fort Wayne Birth Center is our birth center website. Again, even if you don't plan to travel to Fort Wayne to deliver your child, you could learn a lot about what's possible wherever you happen to live. Those are two good places. Dr. Chris Stroud on Instagram and Dr. Chris Stroud on Facebook, and I'm on TikTok and all the crazy platforms. So please seek us out. If you would like and follow and subscribe, all those words that I forget what they mean, but do that because the evil algorithms use that to steer people our direction. And if they get steered our direction, then what they hear is going to be true and authentic, and not some quackery. So that you're evangelizing a little bit when you're steering people through the algorithm to good content providers, and we need more of them.
Yeah, absolutely. And I think that's what I would say. I've said it a couple times in the podcast, but you do really provide great ways to think about child or not childcare, but fertility and medical care. And I love you had a little series there of what was it? It was like what medical professionals say that's wrong or crazy things that medical OBGYNs say.
That was actually
Um,
dumb things doctors say. I got in some big
yeah.
trouble over it.
Did you really? It's so funny though. It was great.
I had some colleagues who were none too pleased with me for that. But, if the shoe fits, right? That's it.
Yeah. I will say it was really insightful and I loved it. So I'm
Well,
here
thank
for
you.
it. You can
You're
say it's
too, you're
Natalie
very
Lair.
kind. I appreciate that. That started almost on a whim as a joke, and it's blossomed into something else. But again, we need more good content creators. And so I hope, an OBGYN somewhere maybe sees my stuff and says, my patients might benefit from that too. I'll do that. And that's what I hope happens.
Yeah. And again, it might also help people understand what they want and so that when they can go and they can advocate for themselves as well. So
Yeah, good point. Absolutely. And let's not, while we're throwing around undeserved compliments, yours are deserved. The work you're doing is great work. It's hard work, but it pays in so many different ways to get authentic information in front of people because it's hard to find and it can be easy to fall into a trap. So, I thank you for the work that you and content creators like you are doing, because it's so valuable. It's just so important.
well, thank you so much. I'm so glad that we were able to talk and hopefully we can talk again.
I would love that. You call anytime. My answer is always yes.
Thank you for tuning in to this episode of Desert Wanderers. If you liked it, give us a thumbs up as well as subscribe down below. We're produced by Salt and Light Radio, so you can find us on social platforms at Salt and Light Radio or Desert Wanderers Podcast. We produce episodes every week and we launch them for you on Wednesdays. So make sure to tune in for next week's episode and we'll see you then.